Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy. This podcast is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. We have a lot of exciting updates to talk about today. Let's jump right in to the FDA approval, finally, of Daraxonrasib. The brand name of this is RasOnQ. Just like it sounds, ending with a QUE, RasOnQ. As a reminder, Daraxonrasib has shown overall survival benefit in the second-line setting of pancreatic cancer compared to physician's choice chemotherapy. Substantial benefit. RAS, we all thought, not we, I always believed we could beat RAS, but a lot of people thought, who are experts on this more than I am, that RAS was undruggable. And so the way this drug works is it binds to cyclophilin A. So these two compounds come together, and then that compound binds to RAS when it's in the on position and prevents it from ever going and being rephosphorylated, inhibiting RAS signaling for mutated RAS as well as wild-type KRAS in RAS, as well as HRAS, which I don't know that I knew there was an HRAS isoform or I'd forgotten it. So this FDA approved, it's commercially available. The drug company says, I've already had a special pharmacy reach out and say, we have this available. So now we have, we kind of knew the benefit. We were excited. We knew the compassionate use program led us to believe this approval would definitely be coming along with the data. We had an idea of the toxicity from the study, but we didn't know as much now that we do, all right, based on, we have the label. So the dose is 300 a day with or without food, once a day. Comes as 100 and 150 milligram tablets, so your dosage form for most folks will be 2 tablets. There are some recommended concomitant medications that are really important for supportive care. 1, topical corticosteroids to the face and chest. 2, an emollient cream to the face and chest. And then avoiding sun exposure, limiting sun exposure, and SPF 30 sunscreen when in the sun. Very similar to type of stuff that you would for EGFR inhibitors. And then there is a consider recommendation for oral doxycycline and minocycline. So the dermatologic side effects, which were, there's a warning precaution statement about that. 86% of people had this, had these side effects. 10% of the time it was grade 3, which is quite a bit. The median time to onset was 13 days for the skin reactions. There's also warnings for stomatitis in 57%, 9% of the time that was grade 3. Median time for that was 22 days, takes a little bit longer, and they recommend chlorhexidine mouthwash or viscous lidocaine to manage that. Diarrhea occurred in 63%, 6% of the time that was grade 3. Median time to onset, 3 days. Very much kind of what you see with a lot of tyrosine kinase inhibitors. You see an early diarrhea that oftentimes patients will develop tolerance to, and they'll kind of get, their GI tract will get used to it. As we'll see, this drug doesn't have has good enough bioavailability, but as that drug just sits in the GI tract, there's some irritation that people can hopefully get used to. Median time to improvement for the diarrhea is 3 days. So it happens quick and it tends to resolve quickly. Use standard antidiarrheal medications. Only 8% of the time do people have to hold the drug for diarrhea. And there's also warnings for GI perforation, less than 1%, interstitial lung disease / pneumonitis at 2.4%, and embryo-fetal toxicity. What we now have is a really good, a decent summary of the pharmacokinetic profile, which is really important for the pharm listeners in OncoPharm. So this drug has looks like 40% bioavailability. About half the drug is excreted in the feces unchanged. So that probably means not all of it is being absorbed, and probably some irritation of the GI tract. It is 98% bound to albumin. So these folks with pancreatic cancer who are not eating, have low albumin, maybe are going to have more free concentration, free exposure to this drug, perhaps more toxicity, something that we'll monitor and study going forward. Has a half-life of 9 hours. It's metabolized by 3A4. 93% comes out in the feces, 51% as unchanged drug, and maybe 1% of drug is excreted renally. We have a very, very clear recommendation on what to do for drug-drug interactions. And perhaps this was a reason that it took a while for the FDA approval. I had kind of hypothesized that this was a new company. Maybe they weren't sure how to submit the regulatory paperwork to get this drug approved. perhaps they were being very judicious in conducting drug-drug interaction studies to best guide dosing and use of this drug in the real world. And there's some evidence to that. So we have information on recommended doses for drug interactions if you are on a 3A4 inhibitor, a strong 3A4 inhibitor that is also a P-glycoprotein inhibitor. That's itraconazole is what was studied, that increased the AUC fivefold. It's recommended to avoid use with strong 3A4 inhibitors that are also P-glycoprotein inhibitors. We also have a study with strong 3A4 inhibitor that is not a P-glycoprotein inhibitor. These things are not always separated in the PI, the P-glycoprotein and the enzyme, the transporter and the enzyme. With voriconazole, the AUC goes up twofold. So it's a much less severe interaction, even though both itraconazole and voriconazole are strong 3A4 inhibitors because of the differences in blocking that P-glycoprotein transport. So we have data on that, and there are, avoid the use in folks on strong 3A4 inhibitors and P-glycoprotein inhibitors. Reduce the dose if they're on a drug like voriconazole that doesn't inhibit P-glycoprotein. For moderate 3A4 inhibitors that are also a P-glycoprotein inhibitor, the example here is verapamil, it is predicted, so not studied, this is laboratory data, predicted to increase the AUC 2.6-fold. If you have a drug that is a moderate 3A4 inhibitor but doesn't inhibit P-glycoprotein, like fluconazole, it's predicted to increase the AUC 1.8-fold. So you reduce the dose for those, avoid the use on drugs like itraconazole. We also expect that, or we know that if you give a drug that is just a P-glycoprotein inhibitor like quinidine, the AUC goes up 1.8-fold. So there is, something that is going to affect the bioavailability of the drug. Clearly, this drug seems to be a substrate for P-glycoprotein in the gut. You block that, you get a whole lot more absorption, perhaps even less diarrhea if more of the drug gets into the blood and instead of staying in the gut. We also know, because this drug is metabolized by CYP3A4, that if you are on a strong 3A4 inducer or a moderate 3A4 inducer, you should avoid the use if you can. But if you're on a moderate inducer, there is clear guidance in the label to increase the dose to 400 milligrams. And if you can't avoid a strong 3A4 inducer, you increase the dose of this drug to 400, which would be 4 100 milligram tablets. So we have some pretty clear guidance. And a lot of times what you see for a drug that is approved via the accelerated approval process, it won't have this clear guidance on what to do for drug dosing. So that is appreciated that we have this drug. Going to be a very, very commonly used drug, clear standard second line for folks, but does have a lot of supportive care concerns as well with some of the toxicity that we do expect for this drug. Okay, moving on. So, a lot of people who listen to podcasts, they're actively trying to learn oncology. I mean, even if you're a seasoned oncology professional, you're still always trying to learn oncology. And so whether you're new or trying to deepen your understanding of other cancers that maybe you don't see, that can be a challenge. And to help, Kelly Carlstrom, founder of Kelly C. PharmD and the ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type, helping you organize key concepts like risk factors, symptoms, biomarkers, staging, and treatment. Download the Learn Oncology Companion in the link in the show notes for free. All right, we have another exciting approval, and this is based on Horizon GEA, and this is the FDA approval of Zanidatamab for HER2-positive gastric cancer. This includes GEJ cancer, that's adenocarcinoma, and esophageal cancer, that's adenocarcinoma. So the esophagus, the proximal or top 2/3 is usually squamous cell. If that becomes cancerous, the bottom or distal 1/3 is adeno usually, and so it includes any of those adenocarcinomas in and around the stomach and the GEJ. Now the approval is a little bit. It's not as simple as the FDA press release, which just says HER2-positive gastric cancer. There's a little bit of nuance to it. Okay. So, and this is a first-line approval. And so it is in combination, Zanidatamab, which is a bispecific HER2 targeting monoclonal antibody. So it targets two different parts of HER2, right? If you think of the monoclonal antibody as you standing with your arms in the air as a letter Y, left hand binds to one part of HER2 or blocks one part, your right hand's a different part. The brand name of this is Ziihera with two I's, like ZII, like two. bispecific 2, right? It targets 2 different parts of HER2. So the approval with tislelizumab, which is a PD-1 inhibitor, it's been approved for a while. I think its first approval was non-nasopharyngeal head and neck cancer. The first approval is with tislelizumab, which I'm just going to say TIS, and platinum and chemotherapy. If you're IHC 3+ or IHC 2+ with ISH positivity. That is the standard kind of historic definition of HER2 positivity. It is approved Zanidatamab with chemo without the tislelizumab only if it's IHC 3+. It doesn't include the IHC 2+ that also have in situ hybridization positivity. There's some nuance to it. We'll see why that is when we go to the study. So this approval is based off Horizon GEA, which is published in NEJM this year. 900 patients randomized equally to one of 3 arms. Zanidatamab plus tislelizumab plus chemo, Zanidatamab plus chemo, or trastuzumab plus chemo, kind of the TOGA regimen. Now, the authors do say, hey, bummer, it's too bad. Keynote 811, which was pembrolizumab plus trastuzumab plus chemo that demonstrated benefit, well, that came out right after they designed the study. So our control arm here is below the standard of care, which would be trastuzumab plus pembro plus chemo. Too bad. We see this quite a bit. The demographics of this study, 55% Asian, 40% white, 70% were gastric, and the rest obviously GEJ and then adeno of the esophagus. 60% had a TAP score of greater than 1%. So a TAP score is tumor area positivity. It's a little bit similar to composite proportion score. In CPS, you are counting the number of cells, immune cells and tumor cells. In tumor area positivity, you're measuring the area of positivity in the tumor. And there's at least one abstract I saw where TAP score was similar to CPS in concordance. So it is a very different level of PD-1 positivity than, kind of we're used to. It's really silly and unfortunate that each drug company has to do their own PD-L1 scoring, which tells me we haven't quite figured this out yet as a society. And then 90% of folks got Kpox, the rest got cis-5FU. So there are 2 comparisons. There's Zanidatamab, tislelizumab plus chemo versus trastuzumab plus chemo. So again, those folks, kind of an inferior regimen there. So our 18-month PFS in this cohort that get 4 drugs versus 3 drugs, 43.9%. Progression-free survival with Zani, TIS, and chemo versus 20.9%. That's a hazard ratio of 0.63. 30-month overall survival was 43.8% versus 30%. That hazard ratio was 0.72. 95% confidence interval was 0.57 to 0.9. Statistically significant improvement overall survival, albeit compared to probably an inferior comparator regimen. Well, they now have the second comparison, which is Zanidatamab plus chemo versus trastuzumab with chemo. So it is still, an inferior control arm, but the experimental arm here is a fair comparison because they're not getting, both groups are deprived of that immune checkpoint inhibition. So in Zanidatamab versus trastuzumab, and they're both getting chemo, the 18-month PFS was 38% versus 20.9%. That hazard ratio was 0.65 with a 95% confidence interval that goes from 0.52 to 0.81. The 30-month OS trended towards significance with a 95% CI 0.64 to 1.01 with continued follow-up, probably will be statistically significant. So we see here what looks like a HER2 antibody that is better than trastuzumab in this disease state, but there's even more nuance. The subgroup analysis, when it looked at those patients who were IHC 2+ but ISH positive, still we would call these folks HER2 positive if they had breast cancer. The hazard ratio point estimate for this subgroup, which is small, because remember most of the folks in this study, 80+% were IHC 3+. So this is probably about 100 patients. The hazard ratio was 1.73 on the wrong side, and that 95% confidence was 1.06 to 2.83. So it looks like Zanidatamab is inferior to trastuzumab for those folks that are IHC 2+, but way better for 3+, which is a little bit hard to wrap your head around and to understand. unless there is something different about these diseases. And so the approval for those folks who are not getting an immune checkpoint inhibitor is just the IHC 3+ disease. If you go back and look at the TOGA study, which established trastuzumab as a standard of care with chemo in gastric adenocarcinoma, 27% of those folks had IHC 2+ disease and ISH positive, and that was a positive subgroup. So it looks like if you're IHC 2+ and HER2 positive, you want to go trastuzumab pembro plus chemo. Otherwise, if you're 3+, zanidatamab, tislelizumab plus chemo probably is what most people will prefer. I'm sure the guidelines will have zani, tis, and chemo as a category 1, and then trastuzumab, pembro, and chemo as category 1 for the 3+, since they're not compared head to head. We do need to talk about the toxicity here. There is a boxed warning now in the label for zanidatamab for diarrhea. In combination with tislelizumab and chemo, these folks, and most of the time capecitabine, a lot of drugs that cause diarrhea, loperamide twice a day, every day for the first 7 days is required, and if they have diarrhea, you continue it. So a lot of diarrhea in this study, enough that there's a boxed warning in the PI, so these folks need to have lots of loperamide on hand, they have lots of water and Gatorade and things like that to make sure they're not getting dehydrated. But looks to be a step forward. And curious to see where zanidatamab goes going further. Another HER2 amplified disease. It previously was FDA approved for biliary tract cancer. Pretty exciting approval in a disease that's pretty darn hard to treat. Of course, the other caveat to gastric adenocarcinomas is Claudin 1813, or whatever that Claudin is, the zolbetuximab target as well, those patients. So a space where we're seeing hopefully some improvement and better care. The last update I have to talk about is also, I think, a big step forward, and that is the Matrix/IELS G32 study, which was published in Lancet in 2026. This is, quote, the largest randomized controlled trial ever in primary CNS lymphoma. So 230 patients who received Matrix chemotherapy for the primary CNS lymphoma. And Matrix is rituximab on day 0 and day 5, high-dose methotrexate 3 grams, 3.5 grams per meter squared on day 1, cytarabine 2 grams per meter squared on days 2 and 3, and then thiotepa 30 milligrams per meter squared on day 4. Pretty darn toxic regimen. If you got 4 cycles of that and did not have any disease progression, and you tolerated that pretty intense chemo, you were then randomized to either 2 cycles of consolidation RDVIC, which is rituximab, dexamethasone, etoposide, ifosfamide, and carboplatin, or autologous stem cell transplant with carmustine or busulfane if you couldn't get carmustine, and thiotepa. So it's a large study. 230 patients get randomized to either consolidation chemo times 2 or auto transplant. 116 patients enrolled in the study but didn't make it to that randomization. Most of the time, 59 of those patients, which is about half, due to toxicity, and 36% due to disease progression. So we have selected now in this analysis patients who have already responded to treatment, and then patients who tolerated Matrix well enough to be considered for auto transplant. And so we see a very wide separations of our progression-free survival curves as well as our overall survival curve, with a hazard ratio of 0.46 for overall survival, a 95% confidence interval from 0.26 to 0.81. Big improvement in overall survival, although if you look at the curves, it looks like we're kind of invalidating the proportional hazard assumption, because initially folks in the transplant arm did a little bit poorer in overall survival, but what looks to be a plateau in those folks who went through 4 cycles of Matrix, got auto transplant. It looks like about 80% long-term survival rate. We do see a plateau after about 2 to 3 years, around 80%. That is a pretty firm plateau. There's not a lot of slippage in the folks who got RDVIC consolidation. We do see things trend down to maybe about 60% long-term survival, but that curve has not yet plateaued. The slope is pretty is not very steep, but it is looks to still be falling. So it looks like a very aggressive standard of care now. We kind of always, this is what a lot of people were already doing. piecing together small studies here and there, but now we have a randomized study that was probably quite an undertaking to get accomplished. So that is what I have for you this week. Thank you so much for listening. You can follow me on X as long as it still exists, and I'm still there. I don't do a whole lot on there, so maybe not. That's at PharmDeepNib. Other social media platforms at OncoPharmPod. I'll probably do more active in social media at some point. I don't know. Anyway, thank you for listening. Until I talk to you again, remember, doses matter.